Hello, everyone. Thank you for joining the MGFA's Research Educational Webinar. Today, we are talking about Vivgart, and we have Dr. Deborah Galinas, the Executive Director of Neuromuscular Medicine at Argenx speaking. Dr. Galinas was the Global Medical Director for Neurology and Immunology at Grifols, a plasma company. She also serves as the Clinical Professor in the Department of Neurology at UNC Chapel Hill. Prior to joining industry, she was the Clinical Neuroscience Research Director at Mercy Health St. Mary's in Grand Rapids, Michigan, and the Director of the ALS and MDA Centers. A veteran of the Army Medical Corps, she has received the Army Achievement Medal, the Army Commendation Medal, and the Meritorious Service Medal. Thank you so much for joining us, Dr. Galinas, and I am going to stop sharing my screen and let you share your screen. As we put on this presentation, please enter your questions in the Q&A box, and we will answer them at the end of the session.
I'm trying to share the screen, but it's not yet letting me. It says that you've disabled participant screen sharing.
Go ahead and try it now.
Now it's working. Thanks.
Perfect.
Can everybody see the screen?
Yes.
All right, let me just get to a slideshow here. All right. And so does it look nice and large?
Yes.
Hopefully. Okay. So today we're going to be speaking about Vivgart, which is a new approved treatment for generalized myasthenia gravis. We're going to be talking a little bit about acetylcholine receptor antibody positive generalized myasthenia gravis. We're going to be speaking about Vivgart, how it works, what the results are, how one can get treatment, how to track your symptoms. And then I'm going to hand over to Ken Bush, who's going to speak to you about how to actually access the drug. So I probably don't need to speak much to this audience about symptoms of generalized MG, because you're all very aware of what they are. But they include eye problems like drooping eyelids, double vision, difficulty speaking or chewing or swallowing or choking on food, head drop because of neck weakness, shortness of breath, arm and leg weakness. Vivgart is, as I mentioned, a newly approved product for adults with anti-acetylcholine receptor antibody positive generalized myasthenia gravis. So let's talk a little bit about MG, how Vivgart works, and this whole mechanism of disease, mechanism of action. So first of all, you should know that we have harmful acetylcholine receptor antibodies in MG. And in fact, in generalized MG, 85% of the autoantibodies are acetylcholine receptor antibodies. However, antibodies on the whole play a much wider role than just autoantibodies. And the real purpose of our antibodies is to protect us against foreign substances, against infection. And for that reason, we have antibodies that subserve different areas. So we have IgG antibodies, which really patrol our blood. We have IgA antibodies, which prevent infection coming from our mucosa, our respiratory tract, and our bladder. We have IgE antibodies, which prevent against parasitic infections and also are the antibodies of allergies. We have IgM antibodies, which help to activate the cell-mediated immune system, and IgD antibodies, which are really simply in that role of sort of expanding from IgM into the other antibodies. So these different antibodies really have distinct roles, as we've spoken about, but most importantly, for those who suffer with myasthenia gravis, the autoantibodies involved in generalized MG of the acetylcholine receptor antibody type are always IgG antibodies. So we're going to be speaking in particular about IgG antibodies and the regulation of IgG antibodies. So here we're looking at a normal nerve muscle junction, and what we can see in a normal situation is that our motor nerve has little packets of a neurotransmitter called acetylcholine. And acetylcholine, when the nerve is fired, when the nerve is excited, the acetylcholine is released into the synapse, which is the area between the nerve and the muscle cell. This acetylcholine makes its way down to the muscle cell, and there it interacts with the acetylcholine receptors that are on the muscle cell surface. Once it interacts with the acetylcholine receptors, we get a sustained muscle contraction. Now, the amount of acetylcholine is very carefully managed by both the nerve and by there are enzymes in the synapse that help to control the amount of acetylcholine that's available. And that's because too much can lead to weakness and too little leads to weakness. So very carefully managed. Now, in acetylcholine receptor antibody myasthenia gravis, what happens is instead of having protective antibodies, patients actually have antibodies that attack their own bodies. And in the case of acetylcholine antibodies, acetylcholine receptor antibodies, they attack the acetylcholine receptor. When they're attacking that receptor, they can cause damage in several ways. They can block the receptor so that acetylcholine can't get to its receptor, or they may result in the receptor actually getting pulled into the muscle and destroyed, or they may activate the membrane attack complex, which destroys the muscle membrane, so that these antibodies do damage in multiple ways. And the contribution of any one way it does damage is totally individual, so that one may have most of the damage because of destruction of acetylcholine receptors themselves. Another may have damage simply because of blockage, and a third may have damage because of damage to the muscle membrane. So what happens? How are IgG antibodies actually regulated? Well, it turns out that there is a special receptor which is present on most cells of the body, but which are definitely present on the cells which line the blood vessels. And this special receptor is called the Fcrn receptor. Now, the Fcrn receptor very closely regulates how much IgG antibody is in circulation at any time. And if an IgG antibody is bound to the receptor, then it is recycled back out into circulation. What we'll find out is if it's not bound to the receptor, then its fate is quite different. Now, what's important to know is that Fcrn receptors help to regulate the concentration of IgG antibodies, which are protective, and also helps to regulate IgG antibodies, which are destructive, like those involved in myasthenia gravis. And so knowing that the Fcrn receptor is very involved in regulating autoantibodies in myasthenia gravis, it became a very interesting target for MG therapy. So what happens when an antibody is not bound to the Fc receptor? Well, what happens is inside the cell, inside the actual muscle cell, that antibody then gets destroyed. And it gets destroyed in a part of the muscle cell called the lysosome. Now, Vivgart is an IgG antibody fragment. So it's not a full IgG antibody, but it has only the part of the antibody that actually interacts at the Fcrn. And so what happens is when it is given to a patient who has myasthenia gravis, it binds preferentially to that Fcrn receptor. The binding of Vivgart is about 100 times stronger than the binding of an IgG antibody, so that when Vivgart is given, it will bind to the receptor, and Vivgart will result in approximately 60% drop in IgG antibodies. Now, the 60% drop in IgG antibodies is worth mentioning because what it tells you is it does not get rid of all IgG antibodies, and that's important because IgG antibodies can be protective. So it leaves 40% of IgG antibodies to help to fight against infection. And yet just that 60% reduction is sufficient that you will see that it makes a big difference for patients' symptoms who have generalized acetylcholine receptor antibody positive myasthenia gravis. So as you can see here, in the presence of Vivgart, those antibodies are destroyed, and again, a 60% reduction in antibody level. So now let's talk a little bit about Vivgart and what are some of the safety information as well as the results of the trial that was done in patients with generalized myasthenia gravis utilizing Vivgart. So first of all, an important safety information is that Vivgart, because it does decrease IgG levels, can increase the risk of infection. And we will go over that in detail with you. In a clinical study that was done, the most common infections were urinary tract infections and respiratory tract infections. The vast majority of those infections were mild to moderate. The majority, as stated right in this statement here. So there were also some changes in blood counts, and again, mild to moderate. What I want to stress is that patients were not on Vivgart only, they were on Vivgart in addition to the other medications that they commonly took for their myasthenia gravis. So they were also on cholinesterase inhibitors or steroids or non-steroidal immunosuppressants such as Celcept or azathioprine, or any combination of the three. But when patients had Vivgart added to their regimen, so as I've mentioned, whether they were on all three of those other oral medications or whether they were on only one of them, what we saw was that the daily activities of patients greatly improved. Now, it's worth mentioning that the FDA likes to have the primary endpoint in trials be a patient-reported outcome measure. So they like us to use the MGADL because patients report what their function is, and it's felt to truly reflect the patient's daily abilities. In this trial, when we added Vivgart to their commonly prescribed medications, we found that 68% of patients achieved significant improvement in their ability to achieve their daily activities. So they improved their everyday daily activities when it was added. In addition, in a different type of outcome measure, using a muscle strength measure, we found that 63% of patients on Vivgart, when added to their oral medications, had a significant reduction in their muscle weakness or improvement in their muscle strength. So let's talk about that primary outcome measure, which is the activities of daily living or the functional measure of MG. This is a scale that has been specifically designed for patients with myasthenia gravis. Higher scores indicate more disability. A totally normal score would be a 0. What we have found is that this scale is both sensitive and specific to changes in MG. What this scale has shown us is that a 2-point change is felt to be indicative of a true change in underlying MG. So in our trial, we said to be a responder with activities of daily living, one had to have at least a 2-point change, and it had to be maintained for at least 4 consecutive weeks. Now, interestingly, in a separate study, not having anything to do with us, when patients with generalized MG were asked, if you had to live like this for the next few weeks, would it be acceptable to you? It turns out that patients who have an MG-ADL score of overall score of 3 or below out of a possible 24 points, they usually indicate that it would be totally acceptable for them to go on living like that. With scores above that, patients increasingly state, no, I don't want to live like this for the next few weeks. This is too much disability. So in terms of safety, the most common side effects of Vivgart were respiratory tract infection, headache, and urinary tract infection. Certainly, there are always other possible side effects, and you should call your doctor for medical advice if you experience any side effects. In addition, you could report your side effects directly to the Food and Drug Administration at 1-800-FDA-1088. Now, let's talk a little bit about how common these side effects were in our trial. So, in our trial, any side effect that occurred in at least 5% of patients who were treated with Vivgart, and which occurred more commonly in Vivgart-treated patients than placebo-treated patients, we recorded. So, as you can see in our trial, 33% of our participants reported a respiratory tract infection. Again, mostly mild to moderate, and 29% of placebo-treated patients reported respiratory tract infection. So you can see that the numbers were close, but that they were slightly higher with Vivgart. Headache, again, 32% of Vivgart-treated patients versus 29% of placebo-treated patients reported headache at some point during the trial. Urinary tract infection, 10% of Vivgart versus 5% of placebo. Again, overwhelmingly mild to moderate. Tingling sensation, which was reported in 7% of Vivgart, was reported in 5% of placebo. And muscle pain reported in 6% of Vivgart, 1% of placebo. Again, mostly mild to moderate. So now let's talk about how Vivgart is given. Vivgart is given in treatment cycles, which consist of 4 weekly intravenous infusions. So what happens is the first cycle is given over a period of 22 days. And then there's a break between cycles before somebody could receive a second treatment cycle. Now, in our trial, we saw that the average time between the first treatment cycle and the second treatment cycle was 72 days. That doesn't mean that in your real world experience, you should expect 72 days between your first cycle and your second cycle. There is a great deal of variability in terms of how much downtime there is between the first cycle and the second cycle. What I can tell you is 1/3 of patients have a very long period between the first cycle and the second cycle. I can also tell you that there are patients who have a very short time between the first cycle and the second cycle. And so truly, your downtime or your time between cycles of infusions will very much depend upon how much your MG symptoms bother you and upon your discussion with your neurologist about those symptoms. The minimum time between the 2 cycles in our study was 28 days. So in our study, patients were not treated sooner than 4 weeks between the 2 cycles. Now, that means we have safety information in Myasthenia gravis for that frequent. It does not mean that patients might not need to be treated sooner. And certainly it does not mean that you could not be treated sooner. It's just that in our trial, the average was 72 days and the minimum was 28 days. So we really recommend, because of the fact that Vivgart is an individualized treatment regimen where you and your neurologist will determine when you should receive your next cycle. For that reason, we recommend that you track your own symptoms and that you work closely with your neurologist so that you can let your neurologist know when you think you might be needing another treatment cycle. We think it's very important to track your symptoms, and we think that the MGADL is a good way to track your symptoms because it can be done in a matter of less than 10 minutes, because most neurologists are familiar with it, and because a 2-point change means that something is likely happening, and only you can determine if a 2-point change bothers you, or if a 3-point or 4-point, wherever your particular level of tolerance is in terms of your myasthenia, it still gives you a way to track it on a regular basis. And I am going to then recommend that we're going to give you more detail, but basically a healthcare professional will help to prepare the Vivgart for your infusion, will check your vital signs before you receive it, will find a vein in your arm so that they can administer the Vivgart, and they will administer it for 1 hour. In addition, they'll monitor you for 1 hour after the infusion. I'm going to now hand it over to my colleague, Ken Bush, who will present from here.
Thanks, Dr. Gelinas, for that information on Vivgart. And I just want to say to the group, it is a pleasure to be with you today. I consider this an honor. Been working with patients starting Vivgart since we launched the product. I'm based in the Southeast region, so I cover Southeast United States and work closely with patients enrolling in the Vivgart Path program, which our patient support program is the Vivgart Path, My Vivgart Path. We are able to help you through this process of getting started on therapy and kind of coach you through monitoring your symptoms, and as Dr. Gelinas mentioned, tracking with the MGADL. So you can go to the next slide. So we're here for you as the nurse case managers. Like I said, we are throughout the nation and we are regionally aligned. So we know we know the physicians that are prescribing, we know infusion centers that you can locate and maybe be able to go to, and what is probably going to help you to decide what's the best option for you. It's also important to know that this is a very tailored program, so the services provided are here to meet your needs, and through the educational plans, through discussions of insurance, and through managing the disease for you and your caregivers. Next slide. So the 4 main pillars I mentioned, we want you to understand your treatment. So how does the nurse case manager help with this? We can review, we'll have all this information Dr. Gelinas reviewed with you. We have that in handouts for you. The nurse case managers, we do individualized calls with each patient that enrolls in our program, review the administration cycle, because I think it's really exciting that this treatment is individualized for you, so we can help you manage and realize the things that will help you decide if it's time for another discussion with your physician about starting therapy. We also can help you along the path of what you should expect during the infusions, look for any barriers and obstacles you may have and help you overcome those. We also have resources to help you empower you to be part of your care team. So not just a passive participant, but give you the knowledge and the background and support to help you have those conversations. And we do that through reviewing the MGADL that was discussed. We actually have symptom trackers that we can send you to help you with those discussions with your healthcare provider, and then continue on with education and follow-up. So next slide. One of the things that I've heard and that I've worked closely, and it's really not a surprise, is the concern of the cost and getting access to this product. So that is another key component of our program, supporting you, the patients, through the process of looking into, and we do a benefits investigation. So we look at your insurance coverage and to see what's covered, what the out-of-pocket may be, and help you overcome any cost concerns. Another specific benefit of this program, once you enroll, is to help you understand any financial assistance programs that may be available, whether that be through independent funding foundations or through argenx's patient copay support program. Next. So I was talking about the resources available. Dr. Gelinas, she reviewed this, is talking about, it was really interesting. I learn more every time on these conversations and these presentations with her, but what is tolerable with you? So each call that we do with you, we can go over the MGADL scoring tool. The resource packet that we send out actually has a journal. So not only do you get to record your score, and we recommend this is weekly, so that when you do have your conversations with your provider, with your neurologist, you can track those and share that information with them. But also in a journal, it has areas where you can make notes of, what was different this week, what's improving, what's working, what are your goals, what would you like to achieve? And so we work together to help you prepare for that follow-up visit with your neurologist for the next visit, because this is, as we mentioned earlier, so individualized for your specific condition and managing your symptoms. Okay. So a key thing here is, once you have discussed this with your physician and you and your physician decide that Vivgart is the treatment for you, it's important that you enroll in our program, and they can do that for you with once they fill out the enrollment form. It comes straight into our program, and then within 24 hours of receiving that, a nurse case manager is reaching out to you to welcome you to the program, give you the details of the program, what to expect, and help you along the path moving forward. Next. So with that, I will turn it back over to Dr. Gelinas, and then we'll see if I think we have plenty of time for questions and answers. But once again, thank you for allowing us to join you today.
I see there is a question about whether there's any hope that it will be approved for seronegative patients in the near future. You should know that although we included all patients in our trial, we were powered only for acetylcholine receptor antibody positive patients, and that's the population that we have indication. However, we remain committed, and we certainly will continue to have discussions with the FDA to see what can be done in the future. I see there's another,
Right.
Shelley, do you want to?
Yes, I'm sorry, I was muted.
Yes.
So Dr. Gelinas, thank you for that great presentation. First, before I start sharing with you all of the great questions, we have many. My name is Shelley Gerson. I'm the Associate Director of Global Patient Advocacy at argenx, and I'm very pleased to be here. I'm happy to see that there are 180 people on the call right now. That's just thrilling that we're able to share this new information with you. And thank you, Dr. Gelinas, for sharing information for the seronegative patients, because we've gotten several of those questions in the Q&A box. But let's move on to some of the other questions. And there seems to be a lot of questions about IVIG. For example, how long do I have to wait before starting Vivgart if I'm on IVIG? Is there any concerns about transition? Can I take IVIG with Vivgart at the same time? What can you tell us about IVIG?
So first of all, I can tell you that there is no problem transitioning from IVIG to Vivgart. There's no mandated period of time that you have to wait. So when your neurologist thinks it's in your best interest to switch you from IVIG to Vivgart, your neurologist can go right ahead and switch you, because Vivgart takes approximately 2 weeks to start working, and because it tends to reach its maximum benefit 1 week after that last infusion, so week 4, I would suggest that you don't wait until you really need your IVIG before you start Vivgart, because you want to give yourself some time. As to the question of can you take IVIG and Vivgart, I want to mention that certainly patients who were in the Vivgart trial, if they needed rescue, they were allowed to be rescued with IVIG. So that means at any point, if you need IVIG, you can receive it again. However, if you give IVIG and Vivgart together, the way that Vivgart works in reducing IgG antibodies, keep in mind, IVIG is basically donated IgG antibodies from 1,000 donors. And so what happens is, if you're giving it together with Vivgart, what you're actually doing is driving down the concentration of your IVIG and therefore potentially reducing the efficacy of your IVIG.
Great, thank you for the thorough answer. And so my question is basically the same, but are there other drugs that would not be used with Vivgart?
There's no contraindicated drug, but what I do want to mention is any drug that is based on a monoclonal antibody. And so this would also include drugs like Cellular, as well as some specialized cancer drugs, which are antibody-based. Any IgG antibody-based therapy, you're going to be driving down the concentration of that therapy and potentially reducing the efficacy of that therapy. So if you are using it concurrently with something like, for instance, Cellular, then you're actually wasting a lot of money for that Cellular because you're driving down the concentration of the drug.
Great answer. So that means that patients would typically be taking other medications you mentioned during your presentation. So just to clarify again, if a person were to start on Vivgart, the medications that they might be taking could include which medications?
So they might include Mestinon, they might include Celcept or mycophenolate, they might include azathioprine, cyclosporin, metformin, other medications and MG. They might include any kind of steroid. Patients may be on drugs because they also have diabetes. They may be on drugs because they also have heart disease or high blood pressure or hyperlipidemia. There's no problem with those medications at all. They don't need to be adjusted. So no contraindication.
Wonderful, thank you. Can you talk a little bit about those patients who are currently on plasma exchange and their transition to Vivgart?
Yes. So again, same answer. You would simply want to start your Vivgart where you had time for Vivgart to be effective. Keep in mind, most patients start to have good effect within 2 weeks. So again, anytime you can transfer from plasma exchange, but ideally, don't wait until you're really desperate for your next plasma exchange. Give yourself time for Vivgart to start working.
Great. And Dr. Delinas, can you talk about, there are many questions here that people want to know. How does Vivgart compare to other treatments? Can you talk a little bit about our clinical trial and the conclusions we can draw and what we can't?
Yes. So we allowed Vivgart to be used along with commonly prescribed oral medications. We did not do a head-to-head trial against IVIG. We did not do a head-to-head trial against eculizumab, so that I cannot tell you that it is better or worse than those other treatments. I can tell you it's very different than those other treatments. I can tell you that it's much more specific for that acetylcholine receptor antibody than those other treatments. But I can't compare them because that's not how the trial was done.
Right, there would have to be a separate study that would take a long time. And so we don't have that answer. And it's difficult sometimes when we can't get the exact answer we want. But then I've had many questions in the question and answer asking that if I take Vivgart, would I be able to reduce or remove all of the other medications that I take for MG?
So that's a great question. And again, the real world is going to tell us how successfully you can reduce those meds. And I understand that there would be a great desire to reduce those meds. Certainly my patients didn't like some of those meds, and I would understand if you don't. But in our trial, we did not allow patients to change their background medication. So once they came in on a certain steroid dose or a certain dose of mycophenolate, they could not then change the dose for the 6 months they were in the trial.
Okay. So there are people who are saying that they're currently on a medication, let's just say Cellcept, and there are some other drugs mentioned, and they're doing pretty well. And they're asking, is it reasonable to switch to Vivgart if they are doing well or currently in remission?
So certainly, I cannot answer that for any individual. That is a very personal question as to whether it's reasonable, advisable, in your best interest. The best person to speak to about that would be your neurologist. And I would say, have a frank discussion with your neurologist about whether your symptoms might improve. Keep in mind, 67% of patients who had Vivgart added to their regimen did have an improvement in their function. So whether or not you need an improvement in your function, whether or not you would like to have an improvement in your function, that's, again, a discussion with your neurologist.
And another way to use the MGADL to really look at your functioning too. That might be some good information to share with your doctor when having that conversation. So let's say someone who is in that position decides with their doctor to give Vivgart a try, and it doesn't turn out the way they expected. Is it possible to stop Vivgart and revert back to a previous treatment other than Vivgart?
That's really an easy question to answer. Yes, at any time, if Vivgart is not working for you, you can go back to your regimen that you thought worked better. There's no problem there at all.
Great. And now there's a question about the type of participants in the clinical trial. Were any of the participants considered refractory? And is there any data on the effectiveness on refractory patients specifically?
Good question. So refractory is a term that means that a patient has tried multiple different medications and either cannot tolerate the medications or does not have sufficient control with those medications. In common conversation, we say you're refractory if you have made a real good effort for a long period of time to use either a steroid and an immunosuppressant or multiple immunosuppressants or a steroid and an IVIG, and that would be, or steroid and plasma exchange. That would be somebody who's refractory. So in our trial, we found that 50% of patients were on both a steroid and a non-steroidal immunosuppressant. So by previous trial wording, they could be called refractory. Did it work in those patients? Absolutely, it worked in those patients. It worked in refractory patients, and it also worked in non-refractory patients. It improved function and it improved strength.
Right. Okay. Are there any health issues that would disqualify anyone from using Vivgart?
That is the beauty of Vivgart. There is absolutely no contraindication to the use of Vivgart.
That's good news, but do they have to take vaccinations, especially for starting Vivgart?
No, there is absolutely no vaccination requirement prior to starting Vivgart.
Okay, let's see. What about COVID-19 boosters or vaccinations and Vivgart? What can you tell us about that?
We shared some of that information at a recent conference, And what we were able to demonstrate was that Vivgart has such a specific mechanism of action simply in reducing the already existing IgG antibodies. It has no effect whatsoever on your ability to mount a new antibody. So if you have a new vaccine challenge, for instance, you can mount antibody response to that new challenge. Similarly, just as a vaccine challenge is simulating some kind of a protein challenge or infection, you would be able to mount IgG antibodies as well. The thing to keep in mind is when we did look at vaccines, because some patients did get vaccinated in our open label trial anyway, we found that patients were able to mount IgG antibodies to the vaccine challenge, but that when they were given the dose, the antibodies dropped down, just like total IgG antibodies do, and then they bounce back up again. And we will have more information that we can share on that in the future.
Well, that's right. We're spending more time studying Vivgart. We haven't stopped. So that's good for everyone to know. Someone had a question about the trial and how many total patients were in the trial. And one of the graphics did say, I think it was the side effect graphics, seemed to say about 80 were on meds and 80 were on placebo. But could you talk to us about the total number of patients in our trials?
There were 167 patients in our phase 3 trial. Our safety information, however, is based on many more patients because it's based on any patient who ever received Vivgart. So many more patients in terms of our safety information. What I can tell you, however, is 84 patients in our phase 3 trial received Vivgart, 83% received placebo. As we reviewed, there was a small difference, but there was a difference where Vivgart treated patients had more upper respiratory tract infection, more headache, more urinary tract infection, tingling, and muscle pain. Now, these were mild to moderate with very, very few exceptions, but it did occur. Hope that answers it.
Yes. Do patients who are taking Vivgart require any pre-medications like Cellular or Benadryl or Tylenol given prior to the infusion?
No, in our phase 3 trial, we had no infusion events, no acute infusion events. We did not pre-treat with Benadryl. We did not pre-treat with Tylenol. However, if you have a history of sensitivity to infusions, if you typically need to be pre-treated, that's something you can discuss with your doctor. Certainly, if you had an infusion-related reaction to receiving Vivgart, then the next time I would recommend considering something like Tylenol or an antihistamine like Benadryl.
Great. Now this person has a question about fatigue. She has continuous symptoms that are really just related to fatigue, but the other symptoms are mostly in check, not really continuous. And she was wondering, while she gets Rituxan infusion and uses Mestin and azathioprine, do you think that this drug might help, that her doctor does not feel that might be a good option?
So first of all, I can't give medical advice without seeing a patient. So first of all, in terms of fatigue and myasthenia gravis, let me start by saying fatigue is very common in myasthenia gravis. When it's muscle fatigue, it may be directly related to the myasthenia gravis. In addition, however, myasthenia gravis can give sleep disorder, and you may have a fatigue that is based on the fact that you're not sleeping at night or you're not breathing well when you're sleeping at night. So there are lots of reasons for fatigue. We will be studying fatigue in future trials, but we didn't specifically measure fatigue in this trial. So I can't really speak to whether this drug makes a big difference in fatigue compared to other drugs that you may be on.
Right. I have only a couple more questions for you, and then we're going to let Ken answer some questions as the nurse case manager with my VYVGART path. But one question is, were there any restorative factors as a result of this new medicine? And I think the question is, were people able to have an impact that allowed them to do things that they weren't able to do before?
So definitely patients reported that they had a fuller level of function than they did before. In addition, patients had more strength than they had before. In addition, quality of life, patients reported that it was better than it had been before. So in terms of a restorative function, if you mean cure, there's no evidence to suggest that this drug cures. However, this drug certainly can improve function and strength, and you can feel better.
That's a good answer. And I think this might be the last question for you, but I do want you to hang on to the call until the very end because something might come up. But someone was wondering whether they would need to have their thymus removed to get Vivgart.
Absolutely not. We had patients in our trial who did have their thymus already removed, but we had patients in our trial who did not have their thymus removed. Now, thymectomy is something that is recommended for patients who are acetylcholine receptor antibody positive and who are young enough and good enough candidates that they should consider it. And the reason why it's recommended is because over time, and I mean over years, the chance that your myasthenia can be controlled with lower doses of medication is greater if you've had a thymectomy. However, we do not mandate thymectomy prior to using Vivgart, and we certainly had excellent response to Vivgart in patients who did not have a thymectomy. And certainly, thymectomy is not an easy procedure, and it's not cheap. So it's not something that you want to say to people, you know, go and have a thymectomy regardless. It's really a very individual decision. I do want to address one other thing that I saw come up, and that was that one patient said their doctor said antibody levels don't correlate with disease severity with regard to acetylcholine receptor antibody levels. And I want to speak to that because in an individual patient, and your acetylcholine receptor antibody level may not correlate with how you are doing. However, in trials that are done, and certainly plasma exchange shows this again and again, when you take a patient population, a whole group of patients with myasthenia, and you drop their antibodies, you improve their function. So antibody levels do correlate with whether or not you're getting better or getting worse in trials.
Thank you. That is a very good clarification. So I'm going to give you a little rest and you can get something to drink. And Ken, you are up now. And there is someone here that is listening to this call, and he started Vivgart infusions last week, but has not heard about my Vivgart path from anyone. Who starts this getting started? Who helps them get started on that?
Thanks, Shelley. So yeah, that's a great question there, and thanks for bringing that up. So my Vivgart path starts with your physician's office, and it's not a requirement that they have to enroll you in the program, but it is definitely encouraged. So you can, your prescription may have been sent directly to the specialty pharmacy that's distributing the drug and setting up the infusions. However, I encourage you to reach out to your physician and ask them to enroll you in the program so that you can get the additional support of this team of nurse case managers for you.
Right. Now, what, as you've said many times before, Ken, that everyone with a chronic illness and especially so in the MG community, cost is always a concern. And some people are wondering how much Vivgart costs if not covered by insurance. Generally, people want to know what it costs. Can you talk a little bit about cost and maybe a little bit about insurance and what you do on your team to do benefits investigation and other resources that you might have?
Sure. So as Shelley mentioned, we do have a team. So in addition to the nurse case managers, we have access specialists, and then we have field reimbursement managers. So I want you to realize that you're supported by a group of people when we're talking about getting access to therapy. But once the enrollment form is completed, that information, it comes in to us, and it has your insurance information there that the office shares with us. The initial step is to do the benefits investigation. And depending on what type coverage you have and who your payer is and who you're insured through, largely determines what your cost will be. So it's really wouldn't be fair for me to tell you, here's what your out-of-pocket cost is going to be. What it is more accurate is to say we do that benefits investigation. A member of the nurse case manager team reaches out to you. We share that information. Here's what your out-of-pocket costs are. We take it the next step further is we also identify resources are available. So we want you to know what your copay is. If you're eligible, we can help you enroll in the argenx copay assistance program. And then we also can identify additional resources to refer you to help cover those out-of-pocket costs. So it is a process, and we realize the concern that each patient has. And that's why I hope you're encouraged to know that you have individualized nurse case manager to help you through that entire process from once the enrollment form is received, throughout your whole therapeutic journey.
Great. Now, are those financial assistance programs specifically for Medicare patients?
So commercial payers are eligible for the copay assistance through argenx, and then we have the foundations that we can give the referrals for the Medicare patients, and any government plans are eligible for the foundation assistance.
Okay. How do we get set up for an infusion if we don't currently have an infusion center?
So there's several options for that, and that's what we're have infusion centers located throughout the nation, obviously. And on our website, you have an infusion site locator. Also, the nurse case manager, when we're doing those calls with you, we look at the options that are near you if your physician hasn't specifically indicated which one that they would like to go to. And then we work with you, the patient, to make sure this is right for you. Is it better to go to the hospital infusion center, or is there a independent infusion center near you? So we help you locate the best site for you and for the needs that you have. And I did see a question come up. Do you have to go, would you go to a cancer center? The answer is yes, they do infusions there. So that would be appropriate if you and your physician decide that that's where the best option for you is. So I will say, since launch, we have utilized many different resources for infusions. The key is finding it and moving you through this process as quickly as possible. So looking for the best option.
Yes. And part of that question about the cancer center also asked if a person could use a port that is for the infusion. That is something that you would work out with your provider, your doctor, and their nurses to make that decision about whether or not that would be an appropriate thing to do for you. Now, I know that it's hard to answer this question, but this is a really important question to a lot of people. And I can help support the answer to this question, but can you give us an idea of what the out-of-pocket costs will be with and without insurance? The numbers, please share them. Everybody wants to know.
Right.
Question.
And that is the question. So from my perspective as your nurse case manager, there again, it is so variable, and I have seen different numbers. So to say a number, I just don't think would be the right answer. And Shelley, I would like to add to that.
Yeah. Thank you. I didn't mean to put you on the spot, and I'm just going to answer you as a longtime patient advocacy person, as a person with my own rare disease. It's not MG, but it's a rare disease, and they have very expensive medicine. So it is always really very dependent on the insurance that you have. And I know that it's very difficult sometimes to understand what that might look like, but you do have to spend some time going through your plan and looking at what the maximum out-of-pocket costs are. You have to look at what medications that you're taking, not just your MG medications, but all of the medications that you take, whether or not you have other people on the plan. There are so many different factors that it would be impossible for us to give you an accurate number. And I know that I try to avoid digging into the insurance because it's overwhelming, but that's something that you really need to sit down and do and work through the insurance plan. But there are some people who don't have insurance. Ken, can you talk a little bit about that?
Yes, I can. So we do have patient assistance programs that you can apply for those who are underinsured or are not insured. So that should not be a deterrent of you moving forward if Vivgart, you and your physician decide that Vivgart is the treatment for you. Definitely ask them to enroll you in the program. We are on this journey with you. We explore all options. I'm telling my current patients, we leave no stone unturned. Back to what Shelley was mentioning earlier, knowing your insurance plan. We look at, is to go under Part B the best option, or is your Part D an option if your drug coverage may be more beneficial or have more, what the cost may be there or easier access through that route. So we look at all of the coverage that you have and discuss with you what is the best option for you to move forward.
Okay, that is good. And that also would apply for commercial insurance as well. That would help determine that. The person who's asking, one of the people asking about out-of-pocket costs is mentioned Anthem. And I know that we did get some information about Anthem or any insurance companies. How do we work with them in terms of helping them to understand Vivgart? Can you talk a little bit about that, or is that something that you want me to chime in on?
Yeah, you can chime in, but I will just briefly mention, we have regional account directors. We have a field-based team that works with all payers. And so they're updating, they're educating, they're sharing some of the similar information that you've heard today with the payers, so that when that application comes in, if they need a prior authorization, we know what they're looking for, we know the information to provide them, and then we can help usher through that process. But we engage all of our resources, and including our regional account directors, to help work with the payers. But yeah, Shelley, add anything you have?
Yeah, so I do want to assure all of you that we have a team of excellent professionals whose job it is to go to the payers and explain to them the value of the medication that we have now, and working with an agreement with them. And if you feel, if you read about an insurance plan that seems to not be favorable or is providing some barriers for you, we would like to know, and you can reach out. I did pop my information and Kathy Perez's information in the chat. So it was Shelley Gerson. It may have gotten lost in all of these comments, but it's in there somewhere. Shelley Gerson, Kathy Perez, and I know Dova has our information, as does Wendy with the MGFA. So if there are questions that we did not answer because we're 1 minute before the end of this program, and I do know that there are questions that were not answered because they were coming into the end, please don't hesitate to, you can reach out to us, but also Dova is going to be giving us the list of questions, and we will make sure we'll get the answers back to you or through Dova if your questions were not answered. Dova, is there anything else that we need to do at this point?
Thank you. No. Okay. Thank you so much, Dr. Delinas. Thank you for the talk. Ken and Shelley, thank you for moderating the questions. I'm just going to share my screen for a moment. I want to thank all of our sponsors for sponsoring these research series: Alexion, Argenx, Janssen, UCB, and Horizon. We really appreciate your time today. You can go to our website and you'll be able to see this presentation uploaded there and on our YouTube channel as well. So again, thank you, everyone. We will try to get all of your questions answered. We know there were many, many questions that were not answered, but we will do our best to get them answered. And everyone have a great day.
All right. Thank you.
Thank you.
Bye-bye.